good pre-afternoon, everybody. I'm not really a morning person, so I don't like to think about it. But I am excited also to be here with you all on today. A little bit about me. I'm a licensed professional counselor. I'm an LPC. I actually specialize in all things trauma, stress, and resilience. And so working with Black and Brown populations, my people, our people, us is what I do. I actually spent a significant amount of time in the city of Chicago myself. So as Lynn was talking, it's like, yeah, Inglewood, I used to hang out there all the time. The west and south sides of Chicago are actually where I did most of my clinical training and where I actually learned to be a clinician. And I am actually from Kalamazoo, so right down 131, not too far from you all who are over in Grand Rapids and Kent County. I currently reside in the Metro Detroit area in Southfield, where I'm continuing the work here on the east side of the state. So this work is near and dear to my heart. I'm actually also a sociologist by training, so understanding systems in the social world. I see your face, Mr. Shackle. Yes, I do all the things making Facebook. But understanding not just how we as individuals come into this world, but then how the various environments that we are in shape us as people is really how I've come to this work and understanding the social determinants. So I will stop talking and pass it over to Danielle.
Well, thank you for that, Allie. Ooh. So I am Danielle. I'm super excited to be here. I have been in the field now since about 2016. I deal with mental health, but my specialty is substance abuse, which I love, love, love. A little bit about me. I am originally from Detroit. I went to Xavier University of Louisiana, a lovely HBCU. And then I obtained my master's from Western Michigan University. I currently work at Grace Health, which is a community health center out of Battle Creek, and I also do some private practice work at ICG, Infinity Consultation Group. So we can put that little plug in there as well. So if anyone is looking for some counselors, you definitely have a few lifelines here. If you need someone that just needs additional resources, we are here for that as well. I'm really excited about today. I hope you can feel my energy through the screen. I can't wait to answer your questions. And thank you so much for being here and for having me today. I guess I should pass it to who's next, Mr.
Nope.
Shackleford?
It is.
Nope,
It is
that's
me.
it. Okay. Oh, his hands is up. He said, no, ain't no introductions over here. Okay, that's
I
okay.
do appreciate the offer.
Okay.
I do appreciate the offer, but y'all are doing an amazing job. Y'all got it.
Okay.
Oh gosh. So thank you all so much for just being here with us today. I'm just super excited. So we're going to jump in because I know when we started talking about mental health and physical health, like people have questions. So we really want to invite people into this space. I have a handful of questions here, but I have worked with both Danielle and Tasha for a long enough time to know one question can fill an hour fooling with us. So we definitely want to invite you all into this conversation. And as I said, I am Dr. Bernice Patterson, and I'm a psychologist, but I'm also a licensed and ordained member of the clergy. And we want to also invite that conversation in with this also because spirituality tends to be a cornerstone of the Black community. And we really believe, as Lynn, to her point, it's really about the way we live and move. And spirituality, whether the person goes to church or not, is a part of how people live. So the first question that I have for you all, and you can feel free, Dr. Paul, if you can answer, great. If not, just keep your camera off and we just gonna know you out here saving lives and being magical. First question is, how would you describe social determinants of health and how do they impact your work?
I mean, I can go first with that. So like I said, I tend to think about people not just as individuals, but their systems that they're walking around in. And so for me, when I have, whether it's a client or I'm doing trainings and consultations, I like to not only know like what are the individuals experiencing, but really deeply understanding, what are the cultures that they are immersed in, right? Both small kind of micro cultures like your culture at work, but then what communities are being served or being represented in this room. And understanding that not just from this deficit perspective of like the depletion of health, but what might also be the resources then, right? What might also be the informal things that are impacting this individual, these group of people on this larger scale that we could use to kind of pour into, right? If we're looking at improving a space, well, what might already be there that we could increase upon as well? So kind of looking at both sides, right? So not just the things around them that might be depleting their health, but what might also be the kind of naturally existing things that could help improve their space as well.
Dr. David Paul, I saw that you came off, so I didn't know if you wanted to answer that question. How would you describe social determinants of health and how do they impact your work?
Yeah, no, I think that social determinants of health are multifaceted. They start, with the community that people live in, their access to resources, their socioeconomic status, institutional factors that are built into how people of color and minorities are treated when they come to the emergency department. One of the things that I think is important is increasing the pipeline of diverse physicians and healthcare leaders so that when patients come in, they can see a familiar face, right? Mm-hmm. You think about the importance of story and your ability to relate to story. And if a patient comes into the emergency department that you can relate to, you can see that person as your brother, your sister, your mom. I just recently had an interaction last week where it was a difficult patient. Patient was complaining about everybody. And I walk in the room and I saw my grandmother in that patient's face, right? I immediately knew how to communicate with this patient. And at the end of that, encounter, she literally told me, you and your team have been the only people who have sat down, explained to me what's going on, have been compassionate, have been understanding. And that's literally because I saw my grandmother in her face, right? And wow. I knew how to break it down, say things, communicate in a way that she could understand, keep it real with her. And those are the kinds of things that are important. So I think as we, diversify healthcare leadership, we diversify folks in medicine, we can break down the barrier of some of these social determinants of health. And at the end of the day, it just boils down to how do you relate to people? How do you treat people as human beings? How do you value their story? Historically, it's been the story of, physicians, nurses, folks in healthcare and the majority community, and not the story of patients and folks from marginalized communities. So we have to shift that focus. Mm-hmm. And I think that's the way to move forward in making some kind of dent on social determinants of health.
Wow. That's so profound to hear you say that, because I think about just even the fact that you're a neurosurgeon, and it's like, so by the time you're coming into a room, it's not a light thing that you've shown up into a room. But to be able to slow down and say, I see you, and I'm going to honor you, and I'm not about to call you Ruth Ann, I'm about to call you Miss Ruth Ann, and I'm going to honor you for who you are as a person and honor your culture, and just how impactful that had to be for her to see this quote unquote young whippersnapper, but somebody who valued her for who she is.
Yeah, most definitely. And just, keeping the conversation going. That's what breaks story, and, respecting people's story is what breaks down social determinants of health. Because when you can do that, socioeconomic status doesn't matter. Where you live doesn't matter. What your disease process, what you look like doesn't matter. Those are the kinds of things that transcend what we think about as being a social determinant of health and limiting people's access and ability to get quality care.
Wow. Thank you so much for that. Tasha, I wanted to go back to a little bit about what you said when you talked about like the systems of people and who they are. Can you say a little bit more about that and how that ends up impacting, especially work around trauma and how we show up in that space?
Yeah, so I think Lynn set it up really wonderfully when she was talking about kind of how you go from these policies down to their impacts on individuals. I think it's about the only place that the trickle down effect is actually a thing. And understanding that a person who shows up into maybe the therapy room is not merely just this kind of bundle of symptoms, right, that just kind of sprung forth from nowhere. Usually, right, we can identify other things that are happening, whether it's interpersonally or even systemically. I think so much, for example, in our community has really re-highlighted how far we have to go when it comes to issues of things like systemic racism, right? That many of us knew had gone anywhere, but this country had decided we were over it, really re-highlighted and know that that's there. Not only is it there, but it's having profound effects on how people are operating in their day to day. Even if nobody came up to me and said a racial slur, that doesn't mean that I'm not being impacted by racism on a day to day. And then also understanding that because of the fact that many of these systems, so things like our educational system, our criminal legal system, because I always hesitate to call it the criminal justice system. When we think about our housing, economics, all of those things are spaces and places in which we are living and then impact the way that I see my world, the way that I see and view myself, which then lead to them bundle of symptoms, right, that you bring into my office later. And so if I'm merely trying to reduce your symptoms, but I'm not addressing the very place from whence they have come, well, then I'm really not doing you much good, right? I'm helping you maybe to cope, but I'm helping you to cope with oppression as opposed to finding a way to eradicate that oppression in the first place. So when we talk about addressing systems and policies, it has implications beyond, right, just what kind of sounds good or these sound bites of the moment, but we're talking about really restoring and leading to real healing, right, as opposed to helping people just kind of deal with and sit with the things that are harming them in the first place.
Wow. You just messed me up with that. Like teaching you to cope with healing versus, cope with like the trauma versus actually healing. So we're asking people to stay wounded. Versus saying, how do I empower you to move from wounded to heal? Not that your wounds aren't real, not that they're not significant, but that does not have to be your portion. That does not have to be your permanent reality, is that you remain in this wounded state.
Absolutely.
Wow. Okay, that's bringing up other questions, but I'm gonna pace myself. Danielle, could you address this question for us, please?
Yeah, so I'm gonna get back to the very first question. And I like to do things so something I learned from my church is two ways you can teach. You can teach at a lamb level or you can teach at a giraffe level. So I like to keep things very, very simple because your giraffe can always come down to the ground, but your lamb can't come up. So the most simplistic way I think of these social determinants is anything that's going to impact your quality of life. Right. So I like to look at the person, I like to look at the problem, and then I like to look at the policy. Okay, so how do I help this person just as they are, help them deal with the problem that is in front of them and navigate it within the policy? Because we know policy takes time to change, right? So if policy takes time to change, I not only need to get this person to what Tasha talked about, is to healing, but some of this is, okay, how do I help you break up some of these survival skills, keep a portion of them because the policy is not changing, but also help you create this caveat so that you can have some healing. And I really like what Tasha said in terms of, problems. Like a person is not the symptoms or the behaviors that is in front of you. So when I'm looking at assessing what a problem is, I'm looking at what's the real issue. And a lot of times it's not that, oh, this person stole something or, oh, this person has been to prison for it. That's not the real issue. It's everything that sits underneath. And a lot of times individuals don't feel like they have the time to deal with what's underneath because they're so busy surviving. And as they're so busy surviving, they're constantly feeling drained, they're constantly feeling empty. And then it becomes this cyclic thing that people get caught into. And so when you're able to like engage in counseling and just to make a little bit of time, it helps you to work on the real issues or the real problems. And also, I think it's so important of helping people to see the difference between their behaviors versus who they are. Because we live in a culture, you are what you do. You are your job, you are your career, you are what your family says. And it's like you cannot keep those merged together, because if you do, you're not going to have a very good identity. And so we know it's important to understand that you're African American, got that. But also as an African American, how do you identify? Who are you? What are the things that you deal with life? What are the things that actually ascribe to you as a person? So I think it's really important to understand that. And all the other definitions of social determinants, they're all out there and they're valid. So I just want to keep it simple, as in, what are the things that are impacting your quality of life? And how can I help you navigate to be able to address those things?
Wow. So especially I think in the world of substance abuse, I think we very easily those who struggle with substance abuse.
Mhm.
But can you talk about how this understanding of people as a whole and not just the things they do
Mhm.
impacts doing that type of work of meeting people in a place of trying to heal in the midst of substance abuse?
I think the first thing is please like let's get rid of this stigma and the stereotype that everybody uses drugs just does it just because they want to.
Mm.
Um, I've worked inpatient, and I would say at least 70% of the people that come into inpatient do not want to use drugs, but have not yet learned that there's something else that they can use and have not yet developed alternatives to stop using.
Mm.
Right. And so that's a misconception. Also, there is science, there is research that talks about the physical dependence of drugs, but also the genetic factors of someone actually becoming addicted to drugs. So it's called a genetic predisposition. And so, in essence, what that means is my grandfather was an alcoholic, my dad is an alcoholic. Guess what? If you start liking alcohol quite a bit, you have high risk of becoming an alcoholic. Now, it is very true that someone who has never drank a day in their life and no one in their family drank can still become addicted to alcohol. But it is that people who have this family genetic predisposition are more high risk to become not only addicted to whatever drug of choice is within the family history, but to any drug, period.
Mm.
So
So
that's definitely something to consider.
I'm in this place where, right. So I'm in this place where I can grab a hold of something and it could be food. It doesn't even necessarily have to be
Oh, yes.
a substance to just be able to say, I'm caught in this cycle of hit the lever, get the cheese, hit the lever, get the cheese. It chasing
Exactly.
endorphins, I'm chasing the dopamine. And now I
Exactly.
find myself in the midst of addiction.
And it's interesting because we really beat ourselves up. So we know that our logic is right here in our prefrontal cortex, right? So we always think, okay, this is the front of our brain. This is the part that should automatically kick in, but that's not true. So our dopamine system is in the more animus part of our brain, which is where our natural instincts come in. So our body is designed naturally to enjoy pleasure. So anything that tells the body it's pleasurable, we continue to partake in those things. So when it comes to food, gambling, sex, overworking, exercising in excessive ways,
Wait,
you can
pause,
be
pause, pause, pause. Say that overworking one more time for the people in the cheap seats, because I don't think people understand. One more time, I'm sorry. Just
okay.
one more again.
Overworking. And let's break down overworking. Okay. So a lot of times people that overwork are doing a couple of different things. One, you're trying to confirm your identity, you're trying to confirm your value through the work and the effort that you do. Other times, people that are overworking are escaping something. I don't want to deal with some form of reality, so I'm going to work all the time because that keeps me busy. Usually, that's what you find people are in those two main categories. Of course, there's other things that can apply, but those are typically the top two things of people that are overworking. Trying to secure myself and who I am, trying to prove something to other people. People pleasing comes in a lot. Or I don't really feel like dealing with reality. And if I'm always at work, I'm always distracted. So
Mm.
that happens as well. So we're looking for some form of pleasure. And whatever that form of pleasure comes through, that is what we can become addicted to. Now, I don't want everyone here to get worried like, oh my gosh, I overwork or I overeat, I'm addicted. Like, let's not DSM-5 yourself, okay? Don't diagnose yourself. Let's just make sure that we are all aware of some of the issues that we deal with so we are not so quick to pass judgment on someone else. So you may do exercise, I may do food, this other person does heroin. And I'm not sure that we're all in any position to judge the other. At the end of the day, there is something that happened and ignited this person to use these substances. Another bias that we want to get away from is everybody that used drugs didn't do it because of some traumatic event.
Mm.
Everybody has not been raped, beaten, abandoned. Some people started using drugs just because it was fun. And then they developed a dependence that they didn't understand. Some people, especially in the opiate world, began to use drugs because of chronic pain. You go get a surgery, your doctor prescribes you oxycodone. Like, and if we go back before they declared that opiates is an epidemic, which I will talk about that later because we really can get into some of the biases and even how drugs and stuff are labeled. I won't go there because I'm on a tangent. But you break your arm, you're given oxy, you're taking it as prescribed, you're still having pain. But what the doctor didn't know then, but they know now, is that, well, your pain tolerance is going to decrease the longer you take those opiates. So guess what? now you can't handle pain and you develop the physical dependence, and people are looking at you like you're a drug addict when it was actually your medical provider that got you started on the medicine in the first place. So we cannot be so quick to place judgment on
Wow.
anyone that deals with any kind of addiction, because it's not always necessarily their fault. A lot of people do not understand genetically, and I mean not neurochemically, well, yeah, neurochemically, but also just with the chemicals that happen in the body that actually build this physical dependence. I think somebody had their hand raised, but they may have taken it down.
Oh, I think that was a hallelujah hand.
Oh, okay. Well, praise God.
It had the sad tilt to it.
Okay.
Bring it, because you know I'm talking.
Go ahead.
If I can take what Danielle just gave us, right, and zoom it out a little bit, right, when we think about genetic predisposition, because I think a lot of times that gets used and abused in some kind of different ways, but thinking about what does that mean for our population in particular? What does that mean for us as Black and brown folks? And when I think about how stress kind of cascades through us. So you might get to the end result of this person who, for whatever reason, to Danielle's point, maybe is utilizing substances to cope with, to deal with, to handle with, or to just feel something that doesn't suck. But when I think about two individuals, right, maybe those two individuals have the same genetic predisposition to being susceptible to whether it's substance misuse, disease, severe mental illness, things like schizophrenia and bipolar, have the same genetic predisposition, but one ends up with it and one doesn't. If we backtrack that a bit, what we tend to see is almost like if you got two people who show up to an obstacle course. Same kind of obstacles in front of them, maybe similar kinds of pathways that they're given that they need to take, right? Your different obstacles are your different stressors. But one person shows up and they've got a toolbox, and the other person shows up and they got a backpack full of rocks. And as they go through this obstacle course, you encounter one stressor. Okay, this person gets another tool because they succeeded. Okay, well, this person gets another rock because they fell down. And as you go through, what seemed like we were the same to begin with, right, ends up with one person not only having similar stressors, but additional adversities, right? So when I think about that, I think about not just a person showing up with the genetic predisposition, but now if I also have additional stressors because I'm Black, if I have additional stressors because I'm living in poverty, if I have additional stressors because my schools ain't worth a good gosh darn, and we got computers that are back from 1999, that I have all these additional rocks in my backpack that then make it more likely that this thing is going to come out of me, right? And then the interventions that we get say, oh no, why did you, individual, do that? Right? Instead of looking at the fact that, well, maybe this obstacle course was a little rockier than it needed to be. And oh, wait a minute, why did they get a boulder as opposed to a hammer? And so we put it on the individual and we look at them, and then to Danielle's point, we stigmatize them for then maybe the choices that they've made, or simply reaching for what they know. Right? Yeah. We reach for what we know, what we have access to. If I grow up and I don't know anything about therapy and counseling, but I know that the weed man is on the block every day, right, sun up to sundown, and that I feel better when I get that, I'm going to reach for what I know and what I have real access to, right? Mm-hmm. And so I love this kind of zoom in, zoom out way that we can look at this, and that you can see an individual, yes, for where they are, but then when you zoom out and see all the various things that were in place to get them to that point, we quickly learn that individuals are so much more than what they present to us, right? The communities even are so much more than what we blame them for or stigmatize them for, that there's all these other things working, right? Which is why these individual programs are not enough.
Wow. Exactly. And I want to piggyback off something she said, and I'm going to use the substances.
You knew what you did when you brought us here, Bernice.
I know. Listen, okay. I wrote down 3 questions in the chat. We're going to make sure we get to it. So we haven't forgotten about you. But when we zoom out and we look at legislation, okay, so we know that crack should have been labeled as an epidemic, but it never was. And do we know why it never was? Because it did not impact the majority culture, right? So i.e. it did not impact white or Caucasian people. So even the way legally they justify where they're going to send their funds to and where they're not going to send their funds to. Also, when we look at how much you're going to be punished for having a particular drug, There are still people incarcerated for having marijuana, still people incarcerated for using crack cocaine back in the day. But if you used heroin, well, you know what? I think you should get a lighter sentence. If you use cocaine, oh, you just tooted your nose. Let's get better. But you use crack. Oh, you smoke crack, not crack cocaine. So that's considered to be worse, right? So that is another issue that happens just within the substance use arena, that there are stigmas based on the substance that you use. And there's also, okay, meth. So meth is supposed to be ascribed to usually poor white individuals. So if you have a person who uses meth, oh, you must be poor, you don't have any value. So we see it all the way across the board. Depending on the drug that you use, depends on how much empathy you get, depends on how much legal consequence you will face as well. But there is also a disparity that even if you use the same drug, African Americans are going to get harsher penalty than someone who is white. And that is another like unfairness that exists. If we zoom out, you can see that. And I know some people will be like, no, I think these judges are pretty fair. Like, I'm sorry, but this is why what Dr. Our first presenter, what was her first name?
Dr. Todman.
Dr. Todman, she really hit on that. It's like there are biases that we don't necessarily want to acknowledge. And when we can acknowledge them, we can change them at a greater level so it can have less impact on the individual person. There's no reason why someone that is white who has cocaine gets less time in probation and just pays some fines, while an African American person has cocaine and they're automatically doing 2 to 3 years, right? You're getting a court appointed lawyer that is pushing you to take a plea deal so you can hurry up and get off their caseload, right? So there is a lack of investment in African Americans and in cleaning up their future and their records. I could tell you, like when I worked at behavioral health services at Western Michigan University, and they had a program called 7411. And I had never heard of it until I got there. You know why? Because oftentimes that was not a program that was offered to African Americans. 90% of the people that I talked to that were a part of the 7411 program, they were white. It was not offered to especially Black people, but it was also not offered to a lot of other minorities. So there's a favoritism that occurs in the substance abuse arena, and it is really, really sad. So that's why I say, okay, I look at this person, I look at the problem that they're dealing with, but we have to learn how to navigate the policy. How do we navigate this policy so that they can not only continue to survive, but also can start this process of having some healing? And I'm gonna be quiet now and put my mute on so I don't keep going.
Lord, listen, we in the good water. We in the good water. And we got some great stuff that's coming up in the chat that I want to address, that I think is really speaking to what you all are saying, and it actually transitions us very, very well to the next question. So it says here, I'm going to be a little vulnerable because I appreciate the realness in this conversation. What do you think are the main factors that are keeping young Black folks from actually getting their therapy journey started? Since I felt my anxiety around age 15, but it took me until I was 23 to actually go see someone. Best decision of my life. Shout out, because therapy is a unicorn universe, and I'm a big proponent of it. I have close friends that have been through the same trauma as me, and they know they need therapy, but can't seem to actually step foot into the office. How can we assist them in breaking down that barrier?
Oh, I'm gonna hop on this real quick.
How do we get folks in the room with us, ladies?
I'm gonna keep it short because I know Tasha was about to go in. I had to do double dutch. I said that rope open. I'm in there. Okay, so I'm gonna just say a couple of things because I know Tasha's really gonna expand on whatever I say. So the first thing I'm gonna say is there's a lack of trust, right? And that goes back. That is because of racial discrimination. Who wants to go in front of someone that you have never met and tell them the most vulnerable things about your life? And then when you leave, you're going to feel violated sometimes. I can't believe I told them that. I feel so exposed. I should have never shared this information. So definitely a lack of trust. Another thing is we were not taught to go to therapy. We were not taught to deal with our emotions. We are in 2022. I understand some families do this gentle parenting thing and they are just like, oh, honey, you get choice. Like, I didn't grow up like that. Go somewhere, sit down, be quiet, stop crying before I give you something to cry about, okay? So we really weren't taught how to properly deal with our emotions and how to really express them. So that also can be a limitation. And then I'm gonna say one more thing and I'm gonna turn over to Tasha. You said, how can we assist them in breaking down that barrier? Go to treatment yourself. You are the greatest example and role model to anyone around you, because if they see you go and then they see a positive change and they see that you're actually making some differences in your life, it will tempt them to go as well. There's a few other technical factors, like search out a Black male or female therapist if you don't feel comfortable seeing anyone else, right? Because it is helpful to have someone that looks like you and that's been through some things like you. So you don't have to go to when it comes to therapy, you get to choose who you open up to. I'll stop there and I'll give it to Tasha.
This is great. So I think there's a few things. And Danielle has kind of opened the door for many of them. I think first and foremost, going back to just historically, we don't do that, right? That tends to be the thing, like, oh, that's not for us. Like, those people do therapy, right? No, we can all use a little bit of therapy. And I think because of that, we don't understand what it is. We don't know what it could look like. We think it all looks the same. We get these pop culture references. Like, I saw somebody the other day on a TV show doing EMDR. I do EMDR, and what she was doing is not it, right? And so that becomes our reference. Why? Because the people that we know who do go to therapy, we don't know they go to therapy, right? Because that brings me to my second point of what people, it's still hush hush, right? Like, you don't tell nobody about it. It's a secret, right? When I was in the northwest suburbs of Chicago, and if you're familiar with that area, that's where the Muncie is, right? Like, with a T, the Muncie.
Two of them.
And I would be talking to these women, largely middle to upper middle class white women, and would just drop that, oh, I'm going to brunch at 1, and then 2:00 is my therapy appointment. Then I got to get little Jill to Girl Scouts at 3. Like, and it was just very casual conversation. It wasn't this like thing of, well, I got a thing to do. We have to make it not a thing. And so for those who do go to therapy out loud. We talk about any other kind of appointment. And I think, that in and of itself, that normalization helps to reduce that stigma, that fear, right? That's what other people do. No, we do it too. And just like any other kind of doctor's or health appointment, I don't necessarily have to tell you all my business about why I'm going to the doctor, but I might just say I'm going to the doctor. And people don't really blink an eye, like, oh, okay, you okay? Okay, cool. And so just normalizing that part of the conversation. I think in particular, for our Black men, we absolutely have to make more space for our Black men to have more emotions than happy and anger. We absolutely do. And I understand that also historically, it has not been safe to engage in emotion, right? It has not been safe to express. And so we close it down. We teach our children very early, right, to be seen and not be heard very early, because historically it has not been safe to emote, to have these different experiences. And so we have to create these safer spaces, right? And I think, even with that, as much as I am a proponent of therapy and the therapy journey, also reimagining what can be therapeutic. Yes, one-on-one, but we know that in particular, people of color, Black and brown folks, indigenous individuals, we tend to be very communal, which means we exist in community, we heal in community. So finding other ways for us to come together, to share experience, to share healing space and energy together, with one another, just for the sake of being, right? Finding ways to do that, because while we can't all be therapists, we can all be therapeutic. And there are many ways that we can and should explore that for our collective healings, right? And if I can, roll that into the next thing I saw in the chat about Black women and this thought that we can withstand more pain, having these higher pain tolerances. Because I think it comes out not only in the way that we're treated medically, but then also in our mental and emotional health as well, right? So this concept, well documented through research. I mean, I don't have to beat it. It's worth a Google. That historically and even presently, right, very recent research has shown that physicians, when surveyed, tend to perceive Black women as having higher pain tolerances, right? But that message also gets put to us that we have higher tolerances for pain, that we have higher tolerances for stress, and therefore are walking around like Atlas with the weight of the world on our back because we got it. I got it, I'm good, which is also why we're sick and tired of being called resilient, because when we're called resilient, what we hear is you're so strong. Well, I'm tired of being strong. If somebody, you ain't got to take the whole world, but just take like Africa off me, or take Australia, like just take a piece, right? Take a piece off me. And we forget that resilience is not merely just holding the weight. It's not merely just coping. It's the healing. But unfortunately, we have not always gotten to or been given permission to engage in the healing, which could be therapy, to Mr. Shackelford's point, which could be just being with myself, which could be cutting my to-do list down from 20 to 10, right? All of these ways in which we can heal, but for whatever reason, we've been given the message that we don't get to do that.
Yes. I want to address the other comment that I saw. It said therapy in Black culture needs to be normalized. Paying for therapy is still discouraged in some church and in some family settings. So it absolutely needs to be normalized. And I think that there are more efforts coming out to normalize therapy in the Black community. So wherever your reach is, use your voice to say, this is okay to do this. This is a good thing to do. I've tried it. This worked for me. Like, the best advocating you can ever do is experiential. Like, I tried it and it worked. I really want to hit on paying for therapy. Like, if you have insurance, that's the best route to try to go through. If you don't have insurance, like, apply for Medicaid, apply for something so that you'll be able to get those services. Also, there are different agencies and counselors that will do what's that word? Pro bono work.
Yep, and pro bono.
Yeah, pro bono work or sliding fee scale, meaning like they understand that you have a limited budget, pay this amount, and they're willing to write off the rest. So those resources are out there. Now, I want to take a moment to talk about that it's discouraged in some family and in some church settings. So it will be discouraged in some family, but you owe it to yourself to get the healing. And if nobody else in your family wants to be healed, then break that, what I would refer to from a Christian standpoint, break that generational curse, right?
Mm-hmm.
You don't have to live under the guise of everything your family went through. That is not necessarily going to keep you bonded together if you all are broken, if you all are tore up, if you all feel defeated and you all feel drained. That just becomes a reason to get a fifth and pour up. Like, that's not a very good reason to bond, okay? I really want to church on this one too. The church settings. I say this respectfully. If you are connected to a church that does not encourage you to go to therapy, run now. Here's why I say this. God created doctors. He created lawyers. He created preachers. He created counselors. Oh my goodness, what a phenomenon. So if your pastor thinks that you don't need therapy, then tell your pastor, if you ever get a case in law, to come with you to the courtroom and to fight your case on your behalf, because he should know the law, right? Because it's your pastor. He should know all the laws and how to, like, no. Pastors are beautiful to guide you into leadership, to teach you the word of God, and to teach you how to stand on the promises and to get what is in the Bible. But there are other things that pastors are just not actually clinically prepared to do and to deal with. And it does not take anything away from a pastor. If you walk into his office and say, I'm suicidal, and he's like, I'm calling such and such for help, doesn't mean he lacks faith, doesn't mean he lacks power and authority. It just means he knows that he can pray for you and God will intervene, but you still have underlying issues that needs to be worked on. Secondly, and I actually have a client at my main job through Grace Health, and they are part of a church where the pastor told them to stop taking their medication. Run, run, run. I see you, Emma. I know it's insane. I can't believe that a pastor would tell people you don't need that medication. All you need is God. I'm going to tell you, if that was true, the medication would have never been made. It would have never been invented. It wouldn't even be on the earth. God gave us so many different resources so that we're able to use it. And never let anybody make you feel bad for needing medication. Because if you have asthma and you can't breathe, you would not be like, oh my gosh, I can't use my inhaler to open my chest. Like, you're going to use it because you don't want to die, right? So in that essence, like, please do not let anyone get you to a place where you're debilitating because you're ashamed to take medicine. There are other fears that go with medicine that can be addressed. Even with, not all counselors are very well versed in how medicine works, but you will run across a few that are. Like, I am pretty well versed in different mental health medications and, you know, how it will impact your substance abuse and things like that. So try to find a clinician that does know that, or a doctor who's willing to sit down and to explain it to you. I think Emma had a question or a comment. I'm not so sure.
I had clapping hands, but I was also going to ask a question as well because I love what you're saying. You just started touching on it too. Is like, how do you kind of find out if that, like, if a therapist you're seeing or recommending to somebody, or like, just how do you find that unicorn that like knows about medications? And because I find that that is like, even in those who are less hesitant to therapy and mental health services, like medication is one of those points where it's like, like that's something I'm not going to explore. And like, again, that's everybody's choice, but like, I don't know, like, I don't even know how to get informed on that. And I think that like that getting informed about medication as a resource is like, I don't know, important, and something that it's kind of hard to find. And just wondering your thoughts about that.
So
Oh, go ahead, Dave.
really quick, I would say there's a couple different ways. I'm fortunate because I worked inpatient. So not only did we did the detox. So when you do detox, you learn a lot about different medications. And so I just kept that kind of wave and I continue to write it. But one thing you can do is if you attach yourself to like a community health center, there are providers there. So it's like almost like a one-stop shop. It's an all-inclusive environment. So a therapist there has access to a medical doctor. So even if they don't know the medicines themselves, they can talk to the medical doctor and get information and then explain it to you in a way where you can relate to it. I think that would be a good way to be able. Other thing is if you're calling an office and you're trying to make an appointment with a particular clinician, ask the receptionist, what does this provider know about medications and how can they integrate it into my treatment? Maybe not prescribing it, but are they aware of different medications? Another thing too, I'll just throw this out there and I'm going to turn it over to Tasha, is there is genetic testing that you can get done to see what medications work well with you and which ones do not. So I would also recommend if you have clients to do that. And if you have Medicaid, they will pay for it. And most insurances do pay for it. So genetic testing of what medications work with your system or don't work with your system is something else that's available.
Yeah, and I mean, I think you covered just about all of it really beautifully, Danielle. I think the only thing that I would add is just kind of in general, when it comes to seeking services, you are in control, right, as the person seeking services, and you get to interview providers. And so just because someone was recommended to you or because you did a consultation with someone doesn't necessarily mean that they'll be your good fit. So maybe they don't know as much about whether it's medication or your particular challenges, that's okay, right? It doesn't make you a bad patient or them a bad clinician. It just may not be the best fit for you. And so knowing that you can shop around until you find that person who really understands your particular needs, right? I think I'm a phenomenal clinician, but I also know that I'm not for everybody, and that's okay. And I will even recognize, like, you know what? I don't know that I'm the person who can give you what you need. And as a provider, it's not about my ego of how many people can I treat, but how many people can I really help heal. And if I'm not doing anything for you, then my best course of action is to get you to someone who does. And that's where that conversation comes in as well, is because if you come to me and it's for something that's outside of my wheelhouse, but I know other clinicians, right? I know other providers. And so I might be able to say, you know what, maybe I'm not the best fit for you, but Dr. Patterson might have just what you need, or Danielle, she might just have what you need. Or maybe you're going to work with me for therapy. You need some medication. Well, I don't prescribe, but I have some trusted relationships with psychiatrists in the area who do, right? And so I can work with them, get you referred over to them. And so having those conversations, knowing you are not going to offend us if you want to know what we're good at versus what we maybe don't do so much, because ultimately it's about you and it's about your care. And you get to shop around and interview us just as much as we're interviewing.
That part.
Yes, that is so true. It's all about genuinely, it's about having a really good fit. And it's okay if you go to a counselor for the first session and you're like, we don't fit. That's okay to say, I really appreciate the time you gave me, but I'm not sure we're a good fit. Do you have somebody else you can refer to me, or you can start the process over? That is very common. I actually have done therapy myself. The first time, and I'm still in therapy myself, let me put that out there. the first time I went to a therapist, she talked more than I did. And y'all can see I'm pretty chatty. And I said, oh my God, I'm doing therapy on her. This is not why I'm here, right? So it doesn't always mean the first time that you go, it's, that it's going to necessarily work out. I did read a pretty funny comment. Someone said, but Jesus didn't go to therapy. That is true. But we also know that Jesus was different, right? Because Jesus was the Son of God, and Jesus also spent a lot more time in prayer and meditation and studying, right? So the lifestyle that Jesus led allowed him to operate in the flesh and to operate in the supernatural. We are primarily in our flesh, right? And so the temptations that we deal with, we're not handling them like Jesus did. So I understand that Jesus didn't go to therapy, but hear me when it's okay. He gave us permission for you to go now, because if he would not have, he would have never created therapists who were of the Christian faith.
So Danielle, that question had me all tingly over here. I was like, Bernice, you're not on the panel, but you can anyhow for like 12 seconds, and then I'm gonna step back down and be a facilitator. Um, I wholeheartedly agree. Like, as you said, Jesus was not a therapist, but you think about how we even talk about Jesus. We call him a doctor in a sick room, a lawyer in the courtroom. We call him a mighty good counselor. Now, we already called him a lawyer, so I'm pretty sure when we're calling him a counselor, we're not referring to him as an attorney yet again. So though he may not have sat across from somebody and told him where it all began, he oftentimes was the one who was acting as the therapist. He would actually listen to where they were and then help them walk into a place of healing. Healing would happen because people got up and moved. And going to therapy is you deciding to get up and move. And even to the point that, granted, Jesus did not participate in therapy, but he participated in the principles of therapy. You think about Jesus would do a miracle, and then he would steal away to take care of himself, to refresh himself, to pour back into himself, because he knew even in his greatness, in his divinity, he still had to take care of his mental and emotional health to deal with the fools he was sent down here to save. So if God in his divinity knew he had to slow down and take care of himself, who are we to deny ourselves the same little bit of grace and mercy to say, maybe I can't do it all? Maybe I need to take a moment to catch my breath. And to Ashley's point with the church, and I think Shackelford's point of, how do we tear down these barriers and dealing with our pastors? The reality is the body is fitly joined together, with every branch supplying need of the other. So we have to realize that going to therapy is not an indictment of your faith. I think if anything, it is a deeper declaration of your faith to say that, God, I trust you enough to put me in the pathway of the right person to help healing manifest, versus me chasing myself in a circle and hoping that it goes away. You can shout your way through a lot of stuff, but healing requires work. And that ain't just speaking in tongues and falling out. Are you willing to get up and do the work that happens after Sunday morning? So now I'm gonna hush and get off of that, because y'all are getting riled up and started.
No, that's really good. That's good though, because for anyone that is of faith, it can become like paralyzing to think that you need any other help other than Jesus, right?
Mm-hmm.
And so, but God put people together so that we're all helping one another. So it's okay to need help, and it's okay to receive help. And that same principle applies to anyone that may be here, and maybe you're not of any particular faith. You cannot do it alone.
Mm-hmm.
A surgeon cannot perform surgery on himself. He cannot hook up his IV, give himself anesthesia, and then start doing work. It doesn't work that way. And I understand we live in a society where we all can be strong, as Tasha pointed out. We all can be resilient, and you can do it, but we cannot do it alone. Here's the proof. If you're struggling, or if your clients are struggling trying to do it on their own, that's the proof it won't work. It will take other people. Because when you're in your mind, you have your thoughts, and you cycle in your own thoughts that lead you in a spiral that keeps you going down. So something that's very simplistic, like, oh, I'm just not a good person, if you say that to someone else, they can actually point out all these great things about you to kind of help you pull you out of that negative thought. And I love the analogy if two people are walking down the street, one person falls into a hole, how do you get the other person out? Well, you got one person there, you get to pull them out. If you're walking down the street by yourself and you fall into a hole, how do you get out? You can't do it alone. All right, I'm gonna mute. We got any other questions?
Well, it is 10:51, and I want to open it up for questions from the audience, because again, I knew this group we weren't gonna need much and no pre-prescribed questions for us to just to begin to pour into this subject matter.
And before, so if you have questions, we definitely want to get to them, but I want to give you a pre-nugget. So the next part of this session is not going to be me lecturing to you. It's actually truly going to be open discussion and talking about these things specifically as it relates to Black and Brown folks and the social determinants. So know that we will engage in further discussion if for some reason we don't get to your question here, but that the next part is truly open discussion, not lecture. We will hit it.
So Emma has a question. I'm sorry, I'm being moderator and panelist and everything else. I'm sorry.
Fine. Go for it.
All right, so Emma says, do you have recommendations on how to cultivate a safe mental health community for the new American community? New American, are you talking about for people that are like immigrants or people that are coming? Okay. Have you had encounters with members of the new American community or referred new Americans to resources? So I can always speak to this question from my personal experience. Whenever you have someone that's coming in that is completely new to American culture, I think it's important to get to know the culture of the individual in front of you, and then you can help bridge the gap of how to get them integrated into this culture. And I don't like, and I say integrated, not assimilated. We don't want them to change to become the American culture. We still want them to be able to keep their own identities firmly. So I would probably look for who they are, what kind of things that they like to do, what are the struggles that they're having adapting with, and then, okay, what could you do where you were at, and then how do we help you to smoothly transition to what you can do here? Trying to find as many like parallels and similarities instead of only focusing on the differences per se, I think could also be helpful. But I'll open this up to Tasha, and I'm sure Dr. Patterson, you probably even have some answers to that as well.
Yeah, I think if we definitely with starting with what Danielle said, honoring and recognizing the culture from which these individuals may be coming, but just speaking, even just from personal perspective as an Afro-Latina whose family has come from Mexico, right? Understanding that it's not just the fact that maybe these individuals are now newly here to America, but like, what are the implications for me as an individual to engage with these systems, right? When we think about, in particular, our Latino population and ICE raids and the dangers that have been experienced at the hands of our government. And then we're telling them, okay, but now go seek healthcare, go to your doctor, go to your therapist, right? That really may not be the starting place, right? That may not be the beginning of the conversation. And so I think that goes along with this idea of taking those PDs, right, of cultural competence and implicit bias, and then putting them into action. What really happens when maybe I have someone in front of me who maybe is undocumented, but struggling with mental health concerns, or struggling with employment and educational concerns that are then leading to mental health concerns, but there are systemic things getting in the way of them accessing those resources or inducing increased fear and anxiety for accessing those resources. So I think Danielle's exactly right that we want to kind of honor, not kind of, absolutely honor the person and things that they bring into the room and listen. First and foremost, more than anything, asking them what they have accessed or what their hesitancies might be. And as opposed to trying to prove those things wrong of why they shouldn't worry about it, really acting as a thought partner to thinking through how can they engage and how could they engage safely.
Awesome. And the only other thing that I would add to that is be willing to refer people to different services, especially with telehealth medicine. It opens up the state. I'm blessed enough that I do work with Danielle and with Tasha. Not saying Danielle and I live in the same city, but Tasha live on the other side of the state. But I'm quick to send a good old trauma patient right on over to Mrs. Turner and say, yes, I'm good at some stuff, but I know she's magical at that. So being able to open up the space to say, we might not have it here in our city, but how can I get you connected to somebody who maybe is on the other side of the state, but because of the beauties of technology, we're able to bridge those gaps. We have one quick question. I'm saying it's quick. We're gonna hope it's quick because we got like 4 minutes left, and then we'll wrap this up and then we'll transition. And just as Tasha said, it's really going to be more process based for us to continue this conversation in our first workshop. It says, due to the historical trauma our community has experienced with healthcare systems, they often neglect regular examinations and treatment. What therapeutic advice can you give to people regarding their fears related to healthcare in general?
First and foremost, I don't try to convince them that those fears are irrational, because they're not, right? Those fears are very rational and they make sense. That'll be the first thing I tell somebody. That makes sense, right? Whether you have experienced it directly or not, excuse me, doesn't make it any less impactful or meaningful. But then also, take the time again, not to be critical maybe of their not utilizing maybe PCP services or not utilizing therapy until it's a crisis, but really seeking to sit with that individual and understand their individual fears, right? What do you understand of your environment, right, that's leading to your particular experience, right? And then walking through, are there any parts of that you do have control over? Because there are many things that give us anxiety and fear and worry and sadness that are outside of our control, right? And that's fine. And maybe working with me individual is not the place where we will change that, but what are the things that you can do, right, to then improve your health? And I personally, and I said this recently in another little online forum, that I personally view my healing as an act of rebellion, right? As an act of rebellion against all those generational messages that say that I, as a Black woman and as a Latina woman, do not get to have good health, that I don't get to have access to these resources, that I'm going to actively throw off that oppression and do the direct opposite, right, of what they tell me I get to do. And that's the way that I approach my health and healing. But that's my particular voice. And so working with people to find their voice and what does it look like for them to have their version of optimal health, because again, health, well, not again, I don't think we've said this yet, but health is individual, right? So I don't get to tell you what your optimal health is, right? That is for you to decide. And so my job is not to tell you what you need to do, but really to help you come into a space where you feel the power that you truly have to make the choices and decisions that you want, to access those systems in a way that feels safer, right, for you, or might just require a little more bravery, as well as, and this is the last thing I'll say, knowing how to advocate for yourself then when you get into said system, right? Because it's not enough to just go to the doctor, but then know how to advocate for yourself once you are in that space, whether you're with a physician or a mental health professional or whomever, a nutritionist, it doesn't matter. Know how to advocate for yourself so that way you can stand firm and strong in who you are when you engage in these systems that historically maybe have not been kind to people like you.
I agree with everything Tasha says, and I echo that. A couple of things that I would add is, I like to teach people to advocate for their needs. So when someone comes in and they tell me that they had a horrible doctor's appointment, and we talk about everything that went wrong and why they felt this way, I always ask them, well, did you say something? Well, no. And I didn't feel comfortable. I was scared. I teach people you have the right to speak up for your health care and for the treatment you receive. You have the right to put in a formal complaint if you have felt violated and you have been mistreated. Number one thing I do, I teach them that. Secondly, is referrals are life. So if I know of a good doctor in the area, I'm saying, hey, go over here. Now, I do work at a community health center. Now, And we do have some phenomenal providers, and I love them. But sometimes people may not feel like our providers are the best fit. So, what is the next best case scenario? Refer them to somewhere else, because as much as you are representative of wherever you work, you cannot forget that that person and their needs are more important, right? So if they've tried, let's just say, because I had one particular client that tried maybe 4 or 5 different doctors, and they're just like, nobody makes me happy. I said, okay, well, why don't we try a different agency and see if you can find someone there you like? They found a different doctor. They loved it. They're still connected to our agency because they still get their treatment with us through the therapy. So you're able to meet both needs at the same time. Your agency needs if you work for a company, but also you're still able to meet the patient needs. I like referrals, and I work at the community health center. So if I have particular doctors that are my favorites, you probably shouldn't, but I have my favorites. So I would say, check out this person, check out this person. Like, if you can know some of the personalities of some of the providers, that's a big help too, because then you can pair like, oh, this person is good for you for this person's good for you that. So I think I have a big advantage in working in a community health center because I have access to the providers. I know the providers and I'm familiar with them. Otherwise, I would say another thing I've done is research doctors online with my clients. So, okay, what did their reviews say? Oh, they're 4-star. Okay, let's read some of these comments. Or they're like, I want a Black doctor. Okay, well, let's go through all these places so we can see where a Black provider is, and then read their comments. So I just do some research with them because sometimes it can be overwhelming when you feel like you have to do all of that work by yourself. You're already dealing with your medical issue. You don't want to feel like you have to do additional work to find someone else. So I would say help them research if you can, but really, really teaching people to advocate. Like, even if they need to put in a complaint and they're nervous, go through the complaint process with them. It's worth using your voice. And a lot of times I think that Black and brown people feel silenced. And so I am a huge proponent of, let's knock this silence out and let's use our voices to stand up. And I know sometimes people are like, well, I don't want to be perceived as the angry Black man or the angry Black woman, or I don't want to be perceived because I'm a minority as someone who's complicated. If you're being treated unfairly, it doesn't matter. Because if they think of you that way when you're voicing your opinion, they already thought of you that way when you walked in the room. So we can't focus on what they think. We advocate for ourselves and we say what we need, and we talk about fair treatment that we deserve. So that's all I have on that.
Well, we are out of time, so that is a perfect look at. See, the benediction was right there. So again, we want to thank you all for just your vulnerability, and we want to ask you to hold on to that. We're about to pull it on into the next space. And I'm gonna warn you now, because this is about to get real therapeutic, and Tasha and myself, and I don't know, Daniel, if you're gonna be hanging out, but you get this many therapists in a room in a therapeutic space. We about to do some work to really give you all some room to heal. So we want to invite you all again to just to stay tuned in and stay dug in. I hope you all are enjoying this as much as we are. Let's see. So Barb, let me know when I can start, because I saw you need to end the video to start a video. So just give me the green light when we can jump in for the next session.
I do want to say, I know there's,
if I can call an audible, because we've been going strong for a solid 2 hours and change. If we maybe want to give our folks who are listening and viewing a quick break while we transition over.
That would be perfect. How about we take like a 5-minute break? We're going to start back up at 11:10, and folks can use the restroom, water themselves, and caffeinate themselves, and then we will hop back in.
Absolutely.
That's great. Tasha, we could be so in sync. I'm like, okay, I think they need a break. Yeah, that's good.